Good morning, everyone. Well, it's a pleasure to have the opportunity to do this case, and this is actually a live stream. I think we may have somewhere around anywhere from 10 to 20 seconds of delay. Obviously, this is a high definition video going from here, San Francisco, to your location. Just to introduce you regarding this lady, she is approximately 52 years old. When she came to see me, she had teeth numbers 7 and 8 that were endo-treated before, and then subsequently she developed a fairly significant periapical lesion, swelling, fistula formation on the labial side, and she had lost a significant amount of the labial bone. So what was done approximately 5 months ago was to extract those teeth, mix allograft and some autogenous bone particles, graft the area, cover it with a resorbable membrane, and now here we are, we're going to place 2 implants for her. For the purpose of the implants, I have 2 different surgical guides. One of the surgical guides is this one, and this has Anatomage sleeves. So we're going to do a significant portion of the osteotomy with this, but because these are more of a generic guide that's used for multiple systems, there are modifications. The very last portion where we put the implant in, it's not going to be absolutely controlled, but it is very accurate, and there are advantages to this system, and I use this quite often, probably more than the more customized guides, which is the other one that we're going to use. This actually uses the 3 Eyes Navigator kit for the 3 implants. We're going to do tooth number 8 with the Anatomage, and we're going to do number 7 with the 3 Eye kit. They both will have depth control. This will have depth control even at the time of placement of the implant. The other one will not have depth control at the time of placement, but it will have it for most of the osteotomy. There are times that it's better to use the other system, and there are times that it's better to use this system, and we can discuss that further tomorrow morning. So let's start. She's already numb. Gerald's. Thank you. So these guides were made based on the merger that was done with the STL files, in this case from an iTero scan on a CT, and pretty nice fit. I mean, look at this. I prefer this over alginate impressions because, tilt the jaw up a little bit, take a deep breath. I prefer these over alginate impressions because there is more accuracy. There's more accuracy and there are less risks of distortion, and it verifies your CT as well. Okay, so a couple of things. One, it is very easy for you to change and torque the position of your handle. So you have a big fulcrum in here, and if you're not careful, you can actually change those sleeves. So the guides help you, but you can easily affect the guide if you're not aware of how you're managing your handle. So I usually start, there is a prescription for this that the depth is going to be 26 millimeter twist drill or pilot drill. I'm going to start with the shortest one first, which is in this case a 15, because it's less likely to cause that problem. Are we on 400 there? Okay. And one other thing, you cannot get irrigation all the way to the depth. So you have to slow down the speed of your handle, of your handpiece, and give it time. And I tend to hold the handpiece loosely in my hand and then just use my finger when I do this part. And I'm going slowly to give time for the bone to cool down. And we want to make sure, go ahead and put your finger on this side or put your suction to make sure that the guide is seated fully. Thank you. So you want to make sure the guide is fully seated. So that's the first one. Now when you do this, the handle may come off, but that's okay. Now, same thing on this side. So I'm taking my hands away so you all can see. How does your image look over there, Robert?
Very good.
You see how I'm using my finger pressure, not the handle, to go directly where the guide wants to take me, to the depth. Now that I went with the 15, now I go to the 21. So I incrementally advance my pilot drill into that space. And we're going to go to the depth. There is a stop at the end. Again, slowly. There's no reason to rush it. Okay. Yeah. So here's the implant inside these carriers. And that's the cover screw. I usually like to take the cover screw off so we don't throw it accidentally in the patient's mouth. And I'm going to turn the water off for this point. Turn the water off now. So that's a 4-3-15. Okay, Edward, go ahead and get a number 9. I'm going to position it for you. And stay on this middle area so there is less likely that it would cause any problems there. So again, I'm going to go in there and I'm going to push this in with my finger as much as it can on its own. And as you see, I am loosely, I don't know if they can show you my left hand. Show my left hand. So I want you to see how I'm holding the handle in here. So I'm not going to change the position in any way with my left hand because of the fulcrum. So that stop, go to up to 10 newtons now. So my fingers is just apical, straight on the straight axis, controlled by where the osteotomy was done. Go to 15 newtons. Forward 45. Okay, reverse 50. Forward 35. I'm gonna stop there. Okay, so that's 35 newtons there. Now, let's see how that's looking in relation to the... You've got a nice keratinized tissue there. That's a labial bone right there. I'm not gonna pull it off because I want that bone to stay there. I could sink it in a little bit more. I'll make that decision later if I want to. Where we have total control of everything. Open up big. Cheek retractors, are they in there? Good. Let's see that other surgical guide that I was going to use. Is it here? For number 7. Kyle, you get to see this too? Are you seeing that? Okay. So this is for the other side. Open up big. Same thing. Nice snap, right? Nice snap. Now, the palatal, one of the things is the palatal flange may limit your total depth at the end, but that's okay as long as you can get 90% of the implanting totally. The rest of it you can finish it, and I like to finish the very end and see where it's actually ending. So that's why you have to drive this just like you drive your car, the way that it fits you best. Again, same thing. I'm just going to go faster in this case. Most of our osteotomy is done. Okay. We'll just make sure that these are the right ones. Good. This is number 7 we're doing. Okay. I can go faster now because actually we have had osteotomies done before, we're not generating as much heat anymore. I'm just expanding that slowly still. When I say fast, it's still pretty slow. So this is a 15 millimeter length drill, and this is the cylinder that controls that.
Okay.
You can see the bone at the tip of it. So you may want to zoom on this part now. So now we're going to take the implant mount, and that goes inside the implant. There's a small little device in here that can hold it. Right, there we go. And it doesn't have to be too tight, just enough to hold it.
So Dr. Sodeifi, let's take the full 30 minutes, and then maybe do like, finish the surgery, do a recap, and then maybe do questions when we get back.
Okay, that's fine. So this is the implant right there, as you see on the mount. Alright, let's go to program 3 on the 10 newtons in this case, because you have friction. No water, no water. There we go, thank you. This is the implant now, and this is going to go through this sleeve. Go to 20 newtons. So I have a finger pressure on this.
That is perfect.
We're going to go to depth with this. Go to 30 newtons. Go to 35 newtons. Reverse. There is some friction within the sleeve, so that 40 may actually translate to only 35 at the implant. That's it. Stopped. Now that implant is all the way in. We're going to see the positioning of the other 99.
Yes, sir.
Come on. Okay, got it. Everyone can see that. Let me see if I can grab that from you so I can get a good exposure. I'm not going to reflect that side too much because I don't want to lose too much. But I will reflect the palatal side a little bit so we can get some release of the tissue, so we can actually have more of a tension-free closure there. Okay, I'm going to do some paradex irrigation on here, and then what I'm going to do is, after that, I'm going to put the cover screws on. And then keep your section right. So these are the cover screws, and at the end, I'm going to show you where we are. We are maybe about 0.5 millimeter below the bone, and the reason I did that because I figured there may be some bone remodeling around there, and this way we are less likely to have thread exposure. You see that? Where's the other number 9? Okay, so let's have the Vicryl. We can do Vicryl, we can do Proline, we can do Silk. It's just that this is white, it's not going to show as dark lines. I'm going to use this. And I'm going to do interrupted horizontal mattress to get a little bit of tissue eversion. So that's less likely to get dehiscence over the healing, over the cover screws. If you get dehiscence, then I go ahead and put the healing abutments on it early. Yeah, if you get exposure, you want to go ahead and uncover these, because then you're going to end up getting plaque getting underneath there and they get bone loss. Then you can dry it with your gauze. I put a lot of knots on this because I don't want it to come loose. And the nice thing with interrupted horizontal mattress closure, you get more of attachment of the connective tissue below, tighter, and allows a better, more likely fusion of the tissues. Same thing on that side. Just 2 stitches would do it.
Say it again.
We're almost done. I'm gonna try her partial on. See how it fits. Let me irrigate first too. We don't even need any adjustments there. So when you take your x-ray, make sure you take your flipper off. Actually, I'll leave it off now. But here's, bite down, bite your teeth together. Close your mouth. Close your mouth. Good. And you see she's not even hitting on it, which is good. She's not loading it. Because if she loads it, she could potentially press on, if she, one of the things is, even though you may bury this, if they load that flipper and if that acrylic presses on the gingiva, it can cause it to become hypervascularized, and it can also cause it to dehisce. And then you have exposure of the healing caps, exposure of the cover screws, and no matter how small it is, bacteria can get there, and when you go uncover, you may see bone loss. It looks like I don't want to go back the other way, and almost in a ways, the best example to say is we used to buy cars that had no airbags, and I guess it felt okay at that time. But now I think having a car without an airbag, don't pinch it like that, damages the system. Now I think if we have a car with no airbag, it would not be standard. Especially in the aesthetic zone. I find out the quality of the work goes up. The guided surgery does increase expense for the patient, because you will have to spend time on the guide and all the technology involved, and also in what you do. But it's a worth investment, and in my practice, when I show them the difference, almost all of them accepted guided surgery, and we can talk about this further. So in this case, this is obviously someone who volunteered to help in this process with us too, but in this case, the treatment plan was done on the computer. I showed the positioning of the implants and the pros and cons of the different sizes. Number 7 is a 3.25 millimeter implant, because if I was going to do a 4 millimeter diameter, my implant space would have been limited, and that could have led to a possible further bone loss. So really, that was the widest diameter because she just has that small space there. Now the distance between the implants is actually more than what you see there, because that periapical is coming somewhat at an angle. So it's overlapping them, but we can look at it on the CT. We have about 3 millimeters as we go further down between the two implants.